Yeah, okay. Anyway, it's very difficult without the slides, but I tried to give an overview of antiplatelets and anticoagulants. So that's my introduction, right? And as you know, can you hear me, Dr. Guruparan? You can hear, right?
Yes, can hear.
Okay. Okay. Now, when you know, it's very important because antiplatelets act on different receptors and different pathways on platelets. So as you know, aspirin is the commonest antiplatelet we use day to day, which blocks the COX pathway. And there are antiplatelets like clopidogrel, ticagrelor, and the prasugrel, ticagrelor. They act on ADP receptors. And then there are several GP2B or 3A inhibitors that like apiximab. They act on a different receptor. Likewise, you have different receptors and also pathways where the antiplatelets act on platelets. So we have to have understanding how they act. So if you take the summary of antiplatelet drugs, there are several drugs under different categories. Basically, there are four basic categories. One is COX inhibitors, and that is where the oxygenase pathways block, like aspirin. And also there are P2Y2 receptor blockers, like the ones that I have mentioned, clopidogrel, prasugrel, and also ticagrelor. And also GP2B3A receptor blockers, inhibitors, and phosphodiesterase inhibitors. So there are four classes depending on the mechanism of action. COX inhibitors are the common, the pathway is the aspirin that blocks, and P2Y12 receptor blockers. There are reversible, there are some antiplatelets which block the reversibly, there are some antiplatelets which block irreversibly. The reversibly blocks antiplatelets are the ticagrelor and cangrelor. And the irreversibly blocked receptors are the ticagrelor and clopidogrel and prasugrel. And glycoprotein 2B3A inhibitors are the apiximab and tirofiban. And phosphodiesterase inhibitors are the dipyridamole. So basically, there are four classes of antiplatelets act on different pathways on the platelets, and they can be utilized in different clinical scenarios. The antiplatelets which are reversibly blind can be activated once the antiplatelet effect is gone. But irreversibly blind antiplatelets, the antiplatelet activity remain until the platelet get destructed. So that is the other thing that you have to remember. So the reversibly bind antiplatelets, they actually uh, their half-life is short, and in fact, even if you can go for surgery, like patients like who are on ticagrelor or cangrelor, which are short-acting, reversibly bound to platelets, and those drugs actually can be stopped only few days prior to surgery. But the irreversibly blind antiplatelets, its important thing is that you need to stop them at least 5 to 7 days before the surgery, if the surgery is a heavily bleeding surgery, like intracranial surgery. So those are the about the way the receptors are blocked. And then if you have to have understanding on different antiplatelets. So I will talk here the commonest use antiplatelets and their short life, and then how they act. Now, if you look aspirin, it inhibits the COX enzyme, as I mentioned. It takes about 1 to 2 hours to come into action once you give the antiplatelet like aspirin. And half-life is 15 to 20 minutes. So clopidogrel, as opposed, it's about 45 minutes it takes to come into action, and half-life is 6 hours. So likewise, I'm not going to go through each antiplatelet, how they are pharmacokinetics and dynamics. So loading doses, you have to be aware about how you load them, especially clopidogrel. If the patient is not on clopidogrel, if come for a surgery, come with a MI or acute coronary syndrome, or even going for a PCI. Generally, you load them with 600 milligrams. Some give 300 milligrams, but ideally you have to give 600 milligrams. So there's a difference be giving 300 and 600 milligrams. If you give 600 milligrams of clopidogrel, the clopidogrel action comes in a quicker manner. That's why we give 600 milligrams for patients who are awaiting PCI. So prasugrel loading dose is 60 milligrams, and ticagrelor loading dose is 180 milligrams. And the other important thing that you need to remember, now if a patient is already on clopidogrel, and if you want to switch to a drug like prasugrel, then you have to only give 30 milligrams of prasugrel as a loading dose, followed by 10 milligrams daily. But if patient is not on clopidogrel, then of course if you want to load them, you have to load with 60 milligrams of prasugrel. So out of those antiplatelets, the strongest antiplatelets are prasugrel and ticagrelor, but the strongest is prasugrel, but it carries a high bleeding risk compared to other two, like ticagrelor and clopidogrel. So these three drugs are the P2Y12 inhibitors, these three drugs, plus these three drugs. So, having said that, and I will go to the aspirin. So aspirin is given in acute coronary syndrome, where the loading dose of 300 milligrams of soluble aspirin. So unfortunately, in our country, we don't have the soluble aspirin as such, but we give the tablets, chew or we and take, or else we can, make it to a powder and ask the patient to drink 300 milligrams of aspirin. So clopidogrel, as I already mentioned, we give 600 milligram of loading dose in patients with acute coronary syndrome. If you give patients with ACS, ticagrelor, the loading dose is 180 milligrams, as I mentioned. But ticagrelor cannot be given, not ticagrelor, prasugrel cannot be given if there's a history of stroke. That is the other thing that you need to remember. So prasugrel is not given if there's a history of stroke. So you have to get a history very carefully. If you are trying to load prasugrel, if there's a history of recent stroke, then you don't load them with prasugrel because it carries a high bleeding risk. So importance of loading dose. So why we give loading dose rather than giving the therapeutic dose? So the reason that I give you loading dose is to attain the quick plasma level and to make the action quicker. And the main importance of loading dose is average plasma concentration is brought at a steady state as quickly as possible. In some cases, loading doses help to get therapeutic dose in a quickly manner. So basically, the reason why we give loading dose is to get a quick plasma action about antiplatelet effect, and also make sure that patient does not vomit when you give the loading dose, especially when you are giving loading dose for patients on PCI, because it's very important. Sometimes patients vomit, and sometimes you can get stent thrombosis or whatever after the procedure because patient have omitted all the antiplatelets you have given. So loading doses, I have told you the difference of why clopidogrel is 600 milligram is given instead of 300 milligrams, because you can get the antiplatelet effect quickly, and also it inhibits 600 milligrams inhibits more than 40% of antiplatelets very quickly, as opposed to 300 milligrams where the antiplatelet activity comes about 30%. And also time to get the peak action is more when you give 600 milligrams of clopidogrel instead of 300 milligrams of clopidogrel. Yeah, if you give 600 milligrams of clopidogrel, the peak action comes in 2 to 3 hours. Instead of giving 300 milligrams, it takes about 4 to 6 hours to come to the therapeutic dose. So that's about the loading doses. So why we give dual antiplatelets? Is there a, why? What is the indication for give dual antiplatelets? If the patient has come with acute coronary syndrome, like MI or non-STEMI or unstable angina, so there's a clear evidence that patients has to be given dual antiplatelets. And I will show the scientific evidence in the coming slides. And where it shows, it reduces the ischemic events. And also, if you are going to put a stent, it reduces the stent thrombosis. So, in addition, if a patient has already undergone stent, then of course you need to give dual antiplatelets for a period of time. Now, initially they have given 1 year with the adventure of newer stents, newer platform of newer stents, newer better advancement of stenting. Actually, the duration of antiplatelet activity, dual antiplatelet activity coming down. Initially it was 1 year. Now, in fact, people give it to 6 months, but basically it's a 1 year. And also patients who had other risk factors, like who had other ischemic events like TIA, or patient had peripheral vascular disease, patient had a history of CVA. Sometimes we can give, because they have generalized atherosclerosis. Sometimes on those patients also we tend to give dual antiplatelets with careful monitoring for at least a period of 1 year. Sometimes we do continue those antiplatelets more than 1 year, dual antiplatelets in patients who had a very high ischemic events, very high ischemic events. In spite of being on dual antiplatelets, patients at a risk of getting strokes, patient at a risk of getting recurrent MI, then of course you have to give the duration of antiplatelet activity can be extended if the ischemic risk is very high. So ischemic risk calculation is done. Basically, patients' ischemic risk you calculate, and there's a score for that. And basically, you give several marks for them. People who are smokers at a high ischemic risk, patients with diabetes, patients with MI at presentation, prior PCI, and also patients who have smaller stents, and patients who have poor ejection fraction, and those patients at a high risk of getting recurrent events, especially diabetes, patients who are smokers, patients whom the stent size, the diameter is small, patients who have LV dysfunction. So those patients, and also the venous graft interventions, those at a high ischemic risk. So you tend to give longer duration of antiplatelets on these patients who have a high ischemic risk. So you have to take a history, whether they are smoking, whether they have diabetes, whether they have high ischemic burden, and whether they have a small stent sizes, and whether they are LV function, and also whether the intervention is carried out the venous graft. Then if there's those categories are there, then that means they have a high ischemic risk. On those patients, you tend to give to a longer duration. As opposed, at the same time, you has to ask about the age. People who are old, it's better to give the dual antiplatelets for a shorter duration, because they carries a high bleeding risk. And also patients with sometimes renal dysfunction, you have to be careful on giving the dual antiplatelets for a longer duration. And as you know, there were several trials done. CURE trial is one of the trials that has compared aspirin only with aspirin and clopidogrel for secondary prevention after getting an event. And it has clearly shown that when you combine aspirin and clopidogrel, it reduces the mortality as only with aspirin. So it's important to give dual antiplatelets in patients after acute coronary syndrome. And clopidogrel for secondary prevention provides slightly greater risk reduction than aspirin. So if you compare the aspirin and clopidogrel, now they have found that according to the CAPRI trial, clopidogrel per se has some more benefit than aspirin. So what about prasugrel compared to clopidogrel? Now, if you take prasugrel versus clopidogrel, if a patient has a high ischemic risk, recurrent events of MI, recurrent, especially after stenting, then of course prasugrel has more evidence that it will look after the patient very well compared to clopidogrel, because it reduces the ischemic events, but at the expense of increased bleeding risk, because prasugrel carries an increased bleeding risk compared to clopidogrel. But only other thing is you need to ask about a history of stroke. If the patient had a history of stroke, you can't give prasugrel compared to clopidogrel. In that case, you have to give clopidogrel. And so that's about the prasugrel and clopidogrel. And for secondary prevention, so in patients who have not implanted stents, there's no statistical difference between giving clopidogrel and prasugrel. So you can give clopidogrel if you are medically managing these patients, as opposed to patients who have put a stent. Then, of course, if there's a high ischemic risk, it's better to give prasugrel over clopidogrel with aspirin. And what about ticagrelor? So there are head-to-head trials that compared clopidogrel only with aspirin and aspirin with ticagrelor, and it has clearly shown that ticagrelor with aspirin has reduces the ischemic risk compared to clopidogrel with aspirin, according to the plateau study. So if you have a patient who had a high ischemic risk, especially after acute coronary syndrome, it's better to give aspirin with ticagrelor or aspirin with prasugrel compared to aspirin with clopidogrel. So it has shown more benefit with aspirin with prasugrel or aspirin with ticagrelor in patients with high bleeding risk, high ischemic risk. So this slide demonstrates, the next slide demonstrates that um, the duration of antiplatelets depending on few things. So if you want to decide how long you have to give antiplatelets, especially after stenting, there are few factors you need to consider. One thing, what is the indication for putting the stent? If the indication for putting a stent is stable coronary artery disease, like stable angina, then duration of antiplatelets can be minimized, like for 6 months. But if the reason for putting a stent like acute coronary syndrome, like MI, that means patient had a high thrombotic burden or a non-STEMI, those patients, antiplatelets has to be longer duration, maybe 6 to 12 months, maybe 12 months. But on patients whose the indication for revascularization or stenting is stable coronary artery disease, of course, you can do the dual antiplatelets for 6 months. And also, the second thing that you need to look in these patients whom they undergo, one thing is you have to look for the indication, but whether it's a stable angina or acute coronary syndrome. Second thing that you need to calculate is their bleeding risk. Whatever the indication is, if the bleeding risk is high, you can minimize the duration of antiplatelets at least for 3 to 6 months or even 1 month. If the bleeding risk is very high, you can give dual antiplatelets for 1 month, or basically 3 to 6 months. You try to push them at least basically for 3 to 6 months with proton pump inhibitors. But of course, if the bleeding risk is low, you can continue for 1 year. So that's about duration of antiplatelets. So duration of antiplatelet therapy depends on what the type of stent you used and what the indication for revascularization, if the stable angina or whether it's acute coronary syndrome. So that's also important, and also the patient's bleeding risk. All three has to be considered to decide of duration of dual antiplatelet therapy. So having talked about antiplatelets, and let me talk about anticoagulants. So there are several anticoagulants, but the commonest anticoagulant is warfarin. So it blocks antagonizes the vitamin K pathway, and that is the commonest anticoagulant we used in day-to-day practice. We have to have good understanding about the warfarin. So how to select anticoagulant following mechanical or bioprosthetic valves? Now, if there's an indication for prosthetic heart valve, if you put a prosthetic heart valve, you have to decide whether it's a mechanical valve or a bioprosthetic valve. If it's a bioprosthetic valve, if the bioprosthetic valve is kept in a mitral position or a tricuspid valve, then of course we have to give warfarin for 3 months. After that, patient can be put on antiplatelets. But if the patient bioprosthetic valve is in the aortic position, you need not to give anticoagulant from the very beginning. You can just start aspirin low dose from the day of surgery. But if the mitral or tricuspid, you have to give warfarin if the bioprosthetic valve for 3 months. After that, antiplatelet, either aspirin for lifelong. So if there's basically, to summarize, if there's a bioprosthetic valve, you manage the patients with antiplatelets rather than the warfarin. But if the valve replacement in a mitral position or tricuspid valve position where the flow is slow, on those patients, you tend to give the warfarin with a therapeutic INR of 2 to 3 for 3 months, and subsequently you switch them to antiplatelets. But, but if the valve replacement is a mechanical valve, then of course we have to give the vitamin K antagonist like warfarin, and you have to manage the target INR. So if there's an aortic valve replacement, you have to give warfarin to manage the INR 2 to 3. But if the valve is the mechanical mitral valve, of course you have managed the warfarin anticoagulant level at a higher level. Reason is the flow across the atrioventricular valves or the mitral valve position is slow and sluggish. Therefore, tendency to clot in that position is high. So you keep a higher INR value in mitral position, where the INR is, we expect 2.5 to 3.5 in between in patients with who have undergone mechanical mitral valve replacement, as opposed to aortic valve, where the INR target is kept at a lower level in mechanical valves 2 to 3, because the flow rate is very high across the aortic valve. Therefore, tendency to clot is less. So as you know, you have to know the INR target for warfarin. If the patient is undergone DVT, if the reason for warfarin is DVT, then the INR target is 2 to 3. If there's aortic valve replacement, mechanical aortic valve replacement, INR target is 2 to 3. And then the mitral valve replacement, INR target is 2.5 to 3.5. And if the patient triple therapy, sometimes we give triple therapy for patients, and I will come to that slide next. Triple therapy, patients who have had AF, undergone PCI, on those patients, sometimes you have to give dual antiplatelets after putting the stents. But still, patient had an increased risk of stroke because fact that patient has AF. On those patients also you tend to put warfarin, but then the INR target is 2 to 2.5. We tend to have a low INR target on patients who have triple therapy, 2 to 2.5. And also we tend to give the triple therapy, always we combine with a proton pump inhibitor. And the duration is basically, maximally we try to give 4 weeks, and maximally it will be 6 weeks. 4 to 6 weeks time we are going to stop the triple therapy and we go with dual therapy afterwards. And patients with mitral stenosis, other indications, with has AF and history of stroke, in mitral stenosis, the INR targets is 2 to 3. So basically, just to summarize, this is a very important point. Patients who have DVT, we tend to manage the INR 2 to 3. Patients who have the aortic valve, mechanical valve 2 to 3. And patients with the mechanical valve of mitral position, we manage with INR of 2.5 to 3.5. And patients who are triple therapy at a high risk of bleeding, then we manage with INR of 2 to 2.5, and mitral stenosis INR is 2 to 3. And how to select the anticoagulant? And that's also very important, right? And there are newer anticoagulants as well. So basically, that's also very key things on enoxaparin. So if you want to give enoxaparin, you have to give the therapeutic dose. Don't just go. I have seen that people prescribe 60 milligrams BD of enoxaparin, especially patient with acute coronary syndrome or even after DVT. You have to give a 1 milligram per kilogram BD dose. If the patient is 40 kilograms, you have to give 40 BD. If the patient is 50 kilograms, 50 BD. If the patient is 80 kilograms, 80 BD. So, and also if there's a renal dysfunction, you will give a daily dose. And the maximum dose of enoxaparin you can go is 100 milligrams per BD. Suppose if the patient is 140 kilograms, you don't give 140 milligrams BD. You give 100 milligrams BD. That's the other thing that I want to mention. So if you give enoxaparin, the patient is overweight, like 110 kilograms, you don't give 110 milligrams BD. You give 100 milligrams BD. The maximum dose is 100 milligrams BD. And if there's a DVT, the patient then, if there's a DVT prophylaxis, we give 40 milligrams subcutaneous daily. If there's a renal dysfunction with DVT, we give 20 milligrams subcutaneous daily. So that's the other thing that I want to mention about enoxaparin. The key things that you need to remember is it's a 1 milligram per kilogram BD dose. Don't just assume and prescribe, because otherwise it can cause more bleeding if you give it over. and if it is given under, there's an increased risk of ischemia. So you have to really calculate. Look for the renal function. If you want to give enoxaparin, please look the creatinine, and also look the weight. Very important, right? So those are the key 3 things that you need to look if you are giving enoxaparin. So triple therapy. So what are the indications for triple therapy? Where you combine with aspirin, clopidogrel, and warfarin or even NOACs. You can combine for triple therapy. So indication for triple therapy are the patients who had a mechanical valve with acute coronary syndrome. Sometimes patients develop acute coronary syndrome on the presence of mechanical valve. On those patients, you have to give dual antiplatelets and also warfarin for 4 to 6 weeks, and then with the combination of proton pump inhibitor, right? And also the other indication for give triple therapy is if patients has AF with acute coronary syndrome, as I already mentioned. And also the patients sometimes after a MI, when they develop severe LV dysfunction, sometimes patients can have LV thrombus. And when there's LV thrombus, LV clots following MI, we tend to combine dual antiplatelets with warfarin or NOACs for a period of 4 to 6 weeks until the clot is dissolved. But remember, if you use triple therapy, you can use either warfarin or novel anticoagulants. But remember, you always combine aspirin and clopidogrel. For the triple therapy, you don't use ticagrelol or prasugrel, but because of the increased risk of bleeding. So you combine aspirin, clopidogrel, and either warfarin or NOACs, depending on the indication for use triple therapy. If there's a mechanical valve with acute coronary syndrome, you take warfarin. If there's a AF with acute coronary syndrome, you can use either warfarin or NOACs. Even there's a LV clot following MI, either you can use warfarin with triple therapy or you can use novel anticoagulants with triple therapy with antiplatelets. So that's about triple therapy. So calculation of triple therapy, especially after AF with who has undergone PCI or acute coronary syndrome, depends on the CHA2DS2-VASc score. So you can calculate the CHA2DS2-VASc score, and if there's a high score, then you combine, other than the dual antiplatelets, you combine the anticoagulant for those patients. So duration of triple therapy, of course, you tend to give 4 to 6 weeks, and also after basically month of triple therapy, you combine with dual therapy, like basically with clopidogrel with warfarin for another 1 year, and after that you tend to give only the anticoagulant after 1 year. Suppose if the indication like a patient has undergone PCI, then you give triple therapy for 1 month, especially if patient has AF, and then subsequently you give clopidogrel and warfarin or clopidogrel with novel anticoagulants for the next 1 year, and after 1 year you give only the anticoagulant in spite whether the patient had a stenting. So that's about the triple therapy, and I have mentioned that it's very important. I will summarize again. If you want to start triple therapy, you start aspirin, clopidogrel, and warfarin, or aspirin, clopidogrel with NOACs. Do not combine prasugrel or ticagrelol in the regimen. Use warfarin. If you use warfarin, keep INR target at a low therapeutic dose, 2 to 2.5, and always combine with proton pump inhibitor if you are using triple therapy. And NOACs are preferred in patients with AF, and warfarin is used in patients with mechanical valve with acute coronary syndrome. So that's about triple therapy. And the other thing that people you have to know is about the antiplatelets. How do you stop? Because most of these patients who are on antiplatelets are referred prior to surgery and asking to stop, because especially if the surgeon is operating at a place where the high bleeding risk, especially enclosed places like spinal cord or brain, because if course stopping the antiplatelets is better than continue, because there's increased risk of bleeding. And in those patients, especially if they ask to stop the antiplatelets, you must know their half-life and when to stop. If you are on prasugrel, if you're on prasugrel, you have to stop that before 7 days. If the patient is on clopidogrel or ticagrelol, you can stop 5 days prior to surgery. Clopidogrel and ticagrelol. At the time after 5 days, the antiplatelet activity is gone. But prasugrel 7 days before. Clopidogrel or ticagrelol, you can stop 5 days prior. And that is the other important thing that I have to mention. But of course, most of the patients, surgeons, are they can operate with aspirin. But instead, if there's a brain surgery, or if the patient is undergoing spinal surgery, you can stop aspirin also at least 5 to 7 days before the surgery. So when to use warfarin and when to use NOACs? So NOACs, novel anticoagulants, rivaroxaban, apixaban, and these anticoagulants, because it's now widely available in Sri Lanka. And those, of course, in the patients who had venous thrombosis, patients who had pulmonary embolism, and patients with atrial fibrillation, those patients you can put on NOACs instead of warfarin. But of course, warfarin can be given at any indication. But NOACs can be given in patients who had AF, which needs anticoagulation to prevent stroke, and patients with pulmonary embolism, and patients has a history of venous thromboembolism. But patients with tight mitral stenosis or patients who had a mechanical mitral valve, on those patients definitely need to be put on warfarin, and you can't use NOACs in patients with mechanical mitral valve or patients who had tight mitral stenosis. But warfarin can be used in any indication. Another thing that I need to mention is nowadays we tend to switch warfarin to NOACs. We tend to switch. And how do you switch? If there's an indication for starting the anticoagulant is high Chatsworth score, especially in patients with AF, you have to do the INR. If the INR is less than 2, you can straight away start NOACs. Suppose INR is 3, you can't start NOACs. You have to wait until INR drops to less than 2. Once the INR is dropped less than 2, you can start NOACs on patients who want warfarin with AF. So other thing that I need to mention about these novel anticoagulants, you are not using these novel anticoagulants especially on patients with severe liver disease and also patients who have end-stage renal disease. So especially if the patient has end-stage renal disease or the severe liver disease, you do not use NOACs, you prefer warfarin on those patients. But if the renal dysfunction, if the creatinine clearance is more than 15, then of course you can use NOACs or warfarin, both on patients who have renal. If the renal dysfunction is clear, creatinine clearance is less than 15 ml, you don't use NOACs. It's a contraindication to use NOACs. And also patients with severe liver disease. So I try to summarize over this half an hour or so antiplatelets, and I used the importance of antiplatelets, how the antiplatelets act, and different pharmacokinetics and pharmacodynamics of antiplatelets. And I have specifically talk about aspirin, clopidogrel, and ticagrelol, and also the prasugrel, and when to use, when not to use. And I talk about indications for dual antiplatelet therapy. And also I mentioned about triple therapy. What are the indications of triple therapy and how do you proceed with triple therapy? And then I talk about anticoagulants and also the novel anticoagulants and various targets of using this. And also the enoxaparin, the key few things about enoxaparin. And thank you very much. Sorry for, it's unfortunately share the slides in the screen. I tried several times. Sorry for that. And questions are welcome.
It's more beneficial than daily dose in patients with non-drug eluting stents.
No, because as there is no evidence that if you use BD dose, it carries the increased bleeding risk, right? So there's no clear evidence for that. I think answer is very clear that you can use a daily dose. Another thing is non-drug eluting stents. Tendency to stent thrombosis is comparatively less compared to drug eluting stents, because in bare, those are called bare metal stents. So bare metal stents, in fact, duration of dual antiplatelets we tend to get shorter, right? Compared to drug-eluting stents, we give the dual antiplatelets for a period of 6 to 1 year, but bare metal stents we get it shorter, dual antiplatelet therapy. And also other thing is now there's no bare metal stents in the market now. This is gone. It was there when we were registrars, when we were senior registrars, and when we were implanting stents, we used the bare metal stents. Now it's no longer used, right? It's not available in the market now, right? So answer is the clopidogrel BD dose for bare metal stents is no, it's not correct. It's daily dose.
And there is another question. Some patients on aspirin 75, 100, 150 milligram as therapeutic dose. Is there any rationale for different doses?
No, there's no rationale. Therapeutic dose can range from 75 to 100. They say you can give whatever. So 75 milligram is enough, right? There's no rationale giving higher doses, unless you want to get the anti. Now, if you one of the reasons why you give anti-platelets at a higher dose is like patients who have if you want to bring the anti-inflammatory effect of antiplatelets, and you give the higher dose, especially after rheumatic fever and all that. But for the antiplatelet activity, 75 milligrams is enough.
What is the best single antiplatelet for patients who underwent PCI after 1 year?
Now, there's a debate now because various trials have come forward. Um, Either you can use aspirin or clopidogrel. Both are correct, right? But some people use now clopidogrel instead of aspirin for long. But I think most people use aspirin or clopidogrel for lifelong. Problem with aspirin or clopidogrel is aspirin causes more gastric irritation, right? That's the only downside about aspirin. But we generally tend to continue with aspirin lifelong instead of clopidogrel.
The second part of the question is there significant clopidogrel resistance in Sri Lankan population?
Well, I don't think there are trials done, but there's very well, it's a very good point. Clopidogrel resistance is seen in Sri Lankan patients. In fact, I of course has personally experienced clopidogrel resistance in patients, but you know, statistical data is no. I don't think there's statistical data in Sri Lanka. You have to do studies, random studies, and see how many patients had clopidogrel resistance. I don't think that we have. As far as I know, we don't have the data.
Then there is this question. We usually give clopidogrel 300 milligrams stud dose on admission. So if the patient going for PCI, is it enough to load another 300 milligram?
Yeah, that's enough. That's enough. You don't want to give further. Think now for that question, I can expand a little bit more. Some people say if there's a patient is coming with acute coronary syndrome, directly going to cath lab. The patient is directly going to cath lab. You can give aspirin 300 milligrams and you can do the angiogram, because your patient is directly in the cath lab. If there's a block, you are going to open up, especially after STEMI situation. If the patient needs a stent, instead of clopidogrel, you can give ticagrelor or prasugrel. That is better than giving clopidogrel, right? So in patients who are coming directly to cath lab, you can give aspirin only, do the angiogram, The angiogram shows that there's a tight block needs stenting. You can load them with ticagrelol or prasugrel and go ahead with stenting. But if the otherwise, you can just give aspirin and clopidogrel 300 or 600 milligrams. 600 is better, and take them to the cath lab, and you can proceed with the stenting.
And I think that's all we have. Let me thank Dr. Bhatya Ranasinghe for the